It is my pleasure to present the data on the behalf of the European Working Group for Adult ALL. It is a clinical trial that deals with an elderly population with essentially the highest risk type of acute lymphoblastic leukemia, which in the pre-kinase inhibitor era was uniformly fatal unless patients underwent stem cell transplant. So things changed somewhat, and it has become standard to use chemotherapy plus a kinase inhibitor as the treatment for these patients, and in younger patients go on to transplant, but this is not an option in a patient population of this age range. So within the EVAL, we developed a European backbone chemotherapy protocol on which we grafted experimental treatments. And I will present the data on the combination with nilotinib, which has been approved for quite a number of years for chronic myeloid leukemia, but has little experience, but we have little experience in acute lymphoblastic leukemia. The minimal cutoff was 55 years of age. It was only pH-positive ALL, so no CML patients were allowed, and we only allowed a minimal prior treatment as a pre-phase. So these were de novo, newly diagnosed patients. CNS, cranial nervous system involvement, is a problem in this disease, and it was not excluded. Now, this is the treatment schedule. It is, as usual, relatively complicated for acute lymphoblastic leukemia, and I would just like to emphasize different principles of treatment in that we rely heavily during the induction phase on the kinase inhibitor, and we've minimized the chemotherapy in that we only use corticosteroids and essentially one drug called vincristine. During the later consolidation phases, we used a somewhat more intensive regimen using essentially 3 drug combinations. So for this elderly patient group, it is actually a significant intensity of chemotherapy during the later stages of treatment. And we looked at minimal residual disease, specifically at 2 time points, an early one after induction and a later time point to assess the impact of induction and consolidation cycles in conjunction with nilotinib, which was given throughout treatment and without interruption. So this is a planned interim analysis that I am presenting. The study is still ongoing. Of the 56 patients, I can report on 47 which were enrolled at time to provide at least minimum duration of follow-up. And you can see that the median age was 65, but we did include patients up to the age of 85 in this clinical trial. None had CNS involvement. The enrollment started in 2012. It has picked up considerably, and we are going now at a quite good clip of new enrollment. So 47 patients, 87% of them achieved a complete hematological remission. There was a low incidence of treatment failure and induction deaths of 4% and 2% respectively, and in 3 patients there was early discontinuation so that we were not able to evaluate the response within the trial, so these are excluded, although some of them actually achieved a CR later on, but we are not counting them. The median time to achieve this response was 6 weeks. And this is the remission duration. I have to emphasize that the median follow-up is still short. But it seems to be a highly effective treatment in that we've only a few relapses at this time. And if we look at the overall survival, we have in the range of 70% at 30 months. There were a number of patients who actually underwent allotransplant. This was something that was specifically allowed and even encouraged in the protocol. At the present time, there is no survival benefit among the 9 patients who underwent transplant. It will be of interest to see how this will proceed, if the transplant-free patients will do as well as the others. Minimal residual disease is shown here, and it emphasizes that you have a significant further increase with the consolidation cycles plus the kinase inhibitor. So continuing the treatment in this form increases the depth of response. And if we then look at the rate of MRD negativity using high-quality assays, then a quarter of the patients have undetectable PCR during the consolidation cycles, and approximately 80% achieve something that we call a major molecular response. So in conclusion, the data I've presented show that the combination of nilotinib with this age-adapted chemotherapy is highly effective. We do have quite a reasonable overall survival estimate at 2 years of just more than 70%. It does show you that, at least in Europe, allogeneic transplant is still considered an option even in this elderly population, and we will see if it is needed or provides benefit or not. And we do have an encouragingly high rate of molecular responses. And we will await the completion of the study, which is anticipated to occur in a few months' time. And with that, I would like to end by acknowledging the AVOL group. We're quite proud, actually, to have put together several European countries to act, in conjunction with each other, using the same therapeutic regimen, going from clinical trial to clinical trial. Thank you.